Good afternoon, everyone. If you are just joining us, this is the 6th annual AFI Nexus event during National Public Health Week. I am Jan Warren Finlow, the professor and interim chair of the Department of Public Health Sciences at UNC Charlotte. My preferred pronouns are she and hers. I am beyond thrilled to introduce our keynote speaker, Dr. Sandro Galea. Dr. Galea is the Dean and Robert A. Knox Professor at Boston University School of Public Health. While that describes his administrative role, he is more importantly a leader and big thinker in the field of public health, someone who ponders what is happening in our field and in society broadly, integrating historical and sociological perspectives through his unique lens as a physician, epidemiologist, social scientist, and immigrant to our nation. Dr. Galea speaks and writes widely. His most recent book is The Contagion Next Time. He has an insightful TED Med talk on how hate harms our health. And he also has a blog called The Healthiest Goldfish. And you can find all these things on his website, sandrogalea.org, or you can follow him on Twitter at Sandro Galea. And in case you can't tell, I'm a big fangirl. And I do know Sandro through the Association of Schools and Programs of Public Health. And I hope that you will be as inspired as I am to hear Dr. Galea on the importance of data, social determinants, and decision-making advancing population health equity. So let's give a warm welcome to Dr. Galea. And Sandro, you have the stage.
Thank you, Dr. Warren Finlow. Thank you, Jen. That's a really super kind introduction. The only problem with an introduction like that is that I feel like, now I really have to live up to it. So thank you very much. So let me share my screen. Okay, very good. So really, it's a privilege to be here with you all, and thank you for making the time to be part of this this event this afternoon. I'm going to talk about health equity broadly. That's broadly the theme of what I'm going to talk about, but I'm going to talk specifically about how we can use data to inform our thinking about health equity and how that can lead to us making decisions that promote health equity. And a lot of this thinking emerges from a commission that I had the privilege of leading called the 3D Commission. It was a commission on data, determinants, and decision-making that really went all the way through COVID and wrapped up with a report that was delivered to the UN General Assembly in the fall of 2021, last year. And that really involved about 24 people from all over the world who helped sharpen my thinking about these topics. So I just want to start that way by way of acknowledgement. So let me start here. I start with a definition of global health equity because we talk a lot about health equity, and I think sometimes we forget what we're talking about. We mean fundamentally global health equity is a world where health is equitably or fairly distributed between and within countries. I do want to point that while the definition seems straightforward, it is actually quite a radical definition, because if you think about it for a second, health is vastly unequally distributed and inequitably distributed, certainly between countries and also within countries, as we know in this country. But if you think about it between countries, there are life expectancy differences of 20, 30, 40 years, which means by definition, unless you're going to make some biological argument as to why health should be different in different countries, health is unequally distributed and inequitably so because of the element of unfairness in it. So if we say we are committed to global health equity, it means we are really making a big statement and making a big commitment. Now, here's a bit of a longer definition. It's from a paper that we published. And I just want to point out a few things. So equity is the just and fair allocation of resources according to need, which means that equity means justice and fairness of allocation of resources according to need. Unless you're going to make an argument that different people have different needs across countries, it means more or less fair allocation of resources equally across countries. It is the absence of avoidable differences. It means there are no differences that are avoidable because of inequities. And the allocation of resources according to need is in such a way that preventable differences in health outcomes are minimized. Now, once again, I would like to emphasize the sort of how radical this is if we think about it and think about what we want to do to achieve it, that we want to allocate resources in a way that would prevent differences in health outcomes. And as I'm going to make the case in this presentation, it is inequity of resource distribution, or even inequality of resource distribution, just to leave the justice element out of it, that results in inequality of health indicators, and that there's no two ways to think about it. If we want to result in more equal, more equitable health indicators, we need to get to more equitable resource allocation. And I would argue that although this notion may not be as clear as all that in the world, there is a growing awareness of multiple forces that lead to that. We saw and have seen in the past 5 years these civil unrest, that is the largest civil unrest the country's ever had, really larger even than 1968, civil unrest starting from the top left, around gender inequity, among income inequity, among racial inequity, among climate inequity. And these really are reflecting a growing sense of unease that all is not right. All is not right in a world where we have tremendous inequity, and that inequity is visible in our daily lives, in our health, and linked directly to our resource inequity. So let me start with global resource inequity. First, I'm going to start with just resource. I'm not going to touch health first, but I want to make the case for global resource inequity. So I'll start with this. This is income and wealth inequality. Now, this is inequality, which is essentially simply a quantitative inequality without getting into the fairness element, which makes it equity, and looks at income and wealth. So income is on the left and wealth is on the right. The red bar is the top 10% of the global population. So the top 10% of the population holds 50% of the world's income. When you get to wealth, you see on the right, the top 10% of the world's population holds 76% of the world's wealth. That, of course, reflects inequities in income and other resources over many decades and centuries, which accumulates wealth in the hands of many people. I mean, just this slide alone tells us that we have massive resource inequities across the world, which inevitably, as I'm going to get to in a second, translate into health inequities. This looks at the concentration of capital, wealth, and equity across the world. You're really showing that this inequity of capital is everywhere. And the red line, again, is the richest 10%. And consistently across all regions, the richest 10% own between 60 to 80% of wealth anywhere in the world. This looks at the top 10, bottom 50% income ratio. So the darker the color here, it means that there is more inequality in income around the world. And what you see is the most levels of inequality are in South America, Sub-Saharan Africa, and in the Middle East. These are areas, of course, which are also coincide with where there are multiple areas where people are living in poverty in an absolute sense. It is a lot of these inequities that have resulted in civil unrest and things like this, talking about capitalism is not working. And I show this simply to say that I feel like these inequities have resulted in a tremendous sort of reflexive pushback on market economies. In fact, history of the world would suggest that probably market economies are probably most stable of all economies. But of course, when market economies start failing people on the scale that they're failing, then you get a very essentialist pushback against the nature of market economies. And what you're seeing now, interestingly, is a lot of people who are in positions of leadership in these market economies. For example, presidents of big banks saying things like these inequities are no longer sustainable because they recognize that our system of market-based economy, which here is sort of an extreme saying it's not working, is so not serving many people that it can result in a collapse of the entire edifice. So all to say that this global resource inequity is being noticed, and it's being noticed not just because it's there, but because of the impact it has on our daily life, centrally about health, which I'm going to get to in a second. This looks at how we've done in terms of the global income inequality. You know, sometimes in the heated rhetoric of the moment, there's been a lot of heated rhetoric in the moment. You know, you hear a lot of things that talk about this being most unequal time in history. It's not exactly true. I mean, we've actually had roughly similar levels of global inequality for the whole past century. As you see here from 1900, it's been up and down, but roughly the same level. And when you see, again, you look at the top 10%, which is the red line, and the bottom 50%, which is the blue line, when you look from about 1900 on, roughly we've had the same levels of inequality. So this is a glass half full, glass half empty perspective. You can say, well, things haven't gotten worse, but also things haven't gotten better. But really, we as a world with ups and downs have been living in a place where we've had this resource inequity across the world for about the past century. There are other ways in which we can measure axes of inequity. And this, for example, globally looks at inequity by gender and looks at, this is the female share in global income from labor, that women make up about 35% of global labor incomes. Well, of course, gender parity would be about 50%. And that's been consistent. It's been going up a little bit over the past 30, 40 years. And one can look at inequities in other ways, including things, for example, like contributing to climate change, global carbon inequality, with the top 10% of countries producing about 50% of the world's carbon footprint. So it's a global lens. Now let me take a national lens. Let me just zoom in and talk about America. Let's talk about America and talk about resource inequities in America. This looks at income, household income in the 5 income quintiles. So the top line is the richest 20%, and you go fourth, sort of fourth, third, second, bottom quintile. And what I want you to see is that real incomes have really only risen in this country for the richest 20%. It's only the richest 20% where income has risen appreciably. The poorest 80%, which is the other 4 quintiles, have stayed largely the same. And that's actually quite a remarkable state of affairs, that over the past 40 years, real incomes haven't really increased for 80% of the population, which of course shows tremendous resource inequalities right there. Now, in this country, a lot of these resource inequities are mapped on to race. This on the left, you look at income inequalities by race. You see white families have about a 40% greater income than black families. And you see this has been over the past 40 years. Again, you see flat overall because 80% of the population hasn't really increased their income, but white families consistently higher. And on the right, you see wealth, and you see white families about 10-fold more wealth than black families. And that reflects the fact that wealth accumulation reflects greater income over time, which over the generations becomes wealth. And this wealth accumulation differential between families has really extends across multiple other dimensions. This looks at median household net worth by race and education. What you see is that white wealth is greater among all levels of education, even post-college education. You have 4 times greater wealth among white families than black families. And you see the same thing here. You see by income that white wealth is still about twice as higher than is among black wealth, despite higher income. And in fact, when you look at this racial wealth divide in this country, these are 2 bars. The blue bar is 1983, the red bar is 2016. On the left, you look at wealth by all races, which is roughly stayed the same. On the right, then you see it for white families, which you see has gone up substantially. Well, then you see black and Latino families where it has stayed the same or even gone down. And this graph captures it, I think, well. This looks at the gaps in wealth among upper, middle, and lower income families. And what you see here is, you just focus on the right, although they say roughly the same thing. You see lower income families' share of US wealth has stayed the same or gone down. Middle income has gone down. It's only upper income, which is the richest 20% of US families, where their share of wealth of the population has gone up. So it's a deeply unequal world, and it's a deeply unequal country. And it is a very big stretch to say that this inequality does not reflect underlying inequity. Of course, it reflects underlying inequity. There's no reason why one would think that there is any fairness in such systematic maldistribution of resource, either internationally or internationally, which means that these are inequitable distribution of resources. And that inequity in distribution of resources has tremendous implications. I was mentioning earlier, the implications in terms of the instability of around fundamental systems of market-based economies, but also has real implications for health. Now, I haven't spoken about health yet, but now let me get to health. So let me start with health, and I'll start with a tiny bit of good news, because I feel like it's important to start with good news and talk a little bit about the fact that we are in health at the best time to be in human history now. I know it's a tough statement to say, it's a bit provocative at the end of COVID-19, or maybe still in the middle of some COVID-19, but leaving that aside, what I want to point out is this is life expectancy in multiple countries. The longest time series life expectancy available is in the United Kingdom. What you see is that life expectancy sort of trundled along in the 40s with some dips with pandemics for all of human history until about the mid-1800s, 1850s, when then it started rising. And now, of course, in high-income countries, it's all the way up to 80. So in 150 years, we have done this amazing thing where we've doubled life expectancy, where before life expectancy only went up to 40. And that, of course, represents a real triumph of public health. It's a triumph of everything that in this room does, which is the creation of clean cities, safe water, safe food, drinkable, breathable air, safe workplaces, housing, stable housing, affordable and livable wages. All of that is ultimately what has resulted in this extraordinary improvement in life expectancy. And I can show you many slides like this. This looks at global child mortality, which looks at the share of children dying in the first 5 years of life, which in 1800, not so long ago, 200 years ago, was 40% plus of children died in the first 5 years of life. And now that number is much, much lower. But with this progress has come enormous inequality, which is, again, I'm saying inequality becomes inequity because it inevitably encompasses a level of fairness. This looks, the darker the colors, the higher the life expectancy. And what you see here is that there are countries, North America, Australia, Western Europe, where life expectancy is in the 80s, while you have countries in sub-Saharan Africa where life expectancy is in the 50s. Life expectancy in Nigeria right now is about 54, which contrasts with Japan, which is about 84. It's a 30-year difference in life expectancy, which is extraordinary if you think about it. There's multiple different ways that one can measure this. This looks at inequality in life expectancy in 2015 within countries. And what you see is that the different color is the different density of inequality in life expectancy within countries, which there's also tremendous heterogeneity within countries. Now, let me zoom in on the US, as I've done before. Let's start with life expectancy in the US. And this looks at different states in the US. In the US, the darker the color here is, the lower the life expectancy. And you see we have US states which are life expectancy 75, and a lot of life expectancy states where life expectancy is 82. That's a 7-year difference in life expectancy. Of course, that masks even deeper differences. For example, when you look at white women living in Minnesota, life expectancy is 83. Black men living in Arkansas, it's 68. That's a 15-year difference in life expectancy. When you look at census tracts, you have by census tracts. The red is 56 to 75. The green is 81 to 97 life expectancy. So we have a life expectancy gap of about 57 to 77, about 25 years, which is almost the life expectancy gap between countries around the world. And this looks at counties, saying it's about 20-year gap in life expectancy between counties in the US, and as well as a 20-year gap in life expectancy within cities in the US. This is a picture of a paper that came out in Seattle a couple of years ago, showing that the difference between the lowest census tract and the highest census tract, which are just a few miles apart, is about a 20-year difference in life expectancy. Now, in this country, a lot of differences in health are indexed to race, just like differences in resources are indexed to race. And that manifests in a number of ways. And I could talk about many different races. I could talk about American Indian, Pacific Islanders. I could talk about Latinos. Let me just talk about Black and white families here. And this looks at life expectancy. And what you see is that Black life expectancy is, this shows mortality rate, which is the converse of life expectancy, that Black mortality is higher than white mortality in young ages, middle ages, and older ages. Now, just like I'm talking about an index by race, I could show you this, this indexing by multiple other dimensions, including, for example, income. So let's talk about health by income. And remember, I've made the case about the richest 20% with their income going up. And this looks at health then mapped onto richest 20% and the poorest 80%. The green is the richest 20%. The brown is the poorest 80%. And when you look at, this is heart failure, angina, heart attack, and stroke, you see the richest 20%, which remember is the group that really holds a substantial proportion of resources based on increasing income over the past 40 years in this country. That group has substantially lower CHF, angina, heart attack, and stroke. And not only is it lower, the difference between that group and the other group has been increasing. So this is what you see is the green. This is over time. The green is the high resource group. The brown is the low resource group, and which is 20-80, richest 20%, poorest 80%. And you see angina prevalence widening, heart attack prevalence widening. One of the things that I think in public health audiences we sometimes struggle with is to say, okay, well, you're telling us about all these dimensions, but how do they come together? I think it's helpful to actually think about how they come together. So I just want to show you one slide that talks, for example, about how income and race come together. This looks at census tracts. Each dot is a census tract, and there are 6 diseases here: COPD, asthma, hypertension, diabetes, obesity, kidney disease. But they all behave the same way. Maybe just focus on asthma, which is right in the middle of the screen, right here. So if you focus on asthma, what you see is the x-axis is income by census tract, and the y-axis is prevalence of asthma. So each dot is a census tract. And you see through this cloud of dots, right, there's a best fit line that goes right through it, which says the higher the income, the less the prevalence of asthma. That's overall. But then the dots are shaded, and the more purple the dot, the greater the proportion of the Black population. And what you see is that the Black population is concentrated in the lower income, high asthma quadrant of this cloud of dots. And that's true for all the diseases. And that's how income and race come together, which of course shows that it is not simply the material resources as measured by income and wealth that result in the worst health among Black Americans and white Americans, but also many other much harder to measure assets, which broadly now we come to understand through the lens of structural racism. This is another way of looking at things, and here looking at things by education. And this looks at a whole range of different physical function, some difficulty walking, difficulty climbing steps. All I want you to see is that the colors, the dark green is less than high school diploma, going to the hatched green, which is bachelor's degree or higher. In all of these, the more education you have, the less disability you have. I want to make one specific note in the context of assets about economic opportunity, because assets, as I've been making the case, income becomes wealth, and it is all about the life course accumulation of resources that protects our health. And I think without talking about economic opportunity, sometimes there's the danger of saying, well, if you just work harder, you're going to get more income. But I want to make the point that economic opportunity is often patterned by resource availability, and economic opportunity is getting worse. This is chance of making more money than your parents if you were born in 1980. If you were born in 1980, you had a 50% chance of making more money than your parents. If you were born in 1940, you had a 92% chance of making more money than your parents. So, people who are now under 40 have less than even odds of actually doing better than their parents. And when you look at things like childhood opportunity scores, there's a neighborhood where you're born in, and what you see is that the more opportunity you have, the higher your life expectancy. And again, when you look at different neighborhood opportunity and why that works, so the brown is very low opportunity, I don't know, this is light beige is very high opportunity. You see, the more opportunity you have, you're more likely to be in childhood education, to graduate from high school, have better teachers, have more green space, etc. So neighborhood opportunity translates into a whole range of life experiences. And it's then not a surprise that your national childhood opportunity score maps onto your income. The more opportunity in childhood, the more income you have once you hit 35. So this is really to make the point about the life course, and to make the point that when we see things through the lens of the life course, it is opportunity to which one is born that creates the resources that then protect us from our health. I'm often asked when I give talks, what's the one thing I can do to improve my health? And my answer is perhaps a bit sarcastically that you need to choose to be born to well-educated, well-off parents living in a good neighborhood, which of course is something that none of us have control over, but I think it serves to remind us of the luck of our birth and how it is where we're born, the opportunity that is given to us is immensely determinative of the resources we're going to have in our life, and that those resources then become our health. So now let's talk about the consequence of health inequity. So I've made the point that there is tremendous global and national resource inequity. I've made the point, hopefully, that there's global and national health inequity. And let's talk about why that matters. Now, I think it matters to us because we are in public health. It matters to us because this is what we do. But I do think we need to be more rigorous about thinking about how does this matter to us nationally to be able to make the case outside this room. Well, this looks at that American life expectancy in how it compared to other high-income countries. And what you see is overall in the blue, we were gaining on life expectancy compared to other high-income countries until about the 1990s, when we started losing life expectancy compared to other countries. So then we started going down. So this has nothing to do with COVID. Well before COVID, our life expectancy was going down compared to other high-income countries. This looks at us. The purple is us. The green is other OECD or high-income countries. Notice till about 1990, we had higher life expectancy, and then it's been getting worse and worse. And of course, we are now at the tail end of COVID. I'm not talking about COVID much in this talk. I will come back to it at the end, but I do want to point out that COVID has hit this country harder than it has any other high-income country, and our life expectancy drop has been tremendous, higher than other countries. And in particular, it's been a life expectancy drop that is unevenly distributed. Black American men have had a 3-year life expectancy drop, the highest life expectancy drop we've ever had in any group since World War II, among young men going off to war, and among white women, we had a 0.7 year life expectancy drop, a tremendous inequity there, but also still a dramatic life expectancy drop compared to what we have been accustomed to. This is also accompanied by enormous cost to our economy. Like, for example, these are indirect costs to the economy in terms of diabetes, about a $90 billion a year cost of diabetes. And the cost of COVID is largely because of our poor health before COVID that resulted in the conditions we were in. This is an analysis that showed that if we close the racial wealth gap, for example, in this country, we could increase GDP by 4 to 6% by 2028. Now, this was done before COVID. Of course, some things are now different in the context of COVID, but there's tremendous gain that there is for us if we tackle these inequities, these resource inequities that become health inequities. And, we as a country have done well we're doing well. And it is until this turn happened about 30, 40 years ago. This looks at the crude and age-adjusted death rate in the country. If you just focus on this, what you see is that we have, over the course of 1960, if you just focus on the age-adjusted, the blue, we have about 800,000 fewer deaths annually than we had in 1960s. That's a lot of fewer deaths. However, when you compare us to the best performing high-income country, in comparison with Japan, this looks at excess deaths compared to Japan, we have about 870 excess deaths annually. So the gain we made in the past 40 years, because we've done better as a country, we've essentially obliterated because we could be doing so much better. Essentially, we have lost as many opportunities to improve health, lost as many excess deaths as we gained in the past 40 to 50 years. And by the way, it's important to note that a lot of our gain has been because of gain that we've made in the context of reducing death from heart disease, and a lot of those gains are actually slowing down. This looks at the red is heart disease, drop in mortality. What I want you to see is that this drop in mortality has actually been getting less and less. In the 1980s, it was a 4% drop, 1990s, a 2% drop, 2000 was a 1% drop, and in the last decade, it's been less than a 1% drop. That is actually quite terrifying, because what we have been seeing is more and more conditions contributing to loss in life expectancy gain. And what you see is in the younger ages, we're consistently losing life expectancy gain year over year, and this is even before COVID. So, having made the case about resource inequity, made the case about health inequity, and made the case that this has a real cost to us as a society, I think it's important to say, how do we connect the two? What is the connection between resource inequity and health inequity, so that we can be robust in our explanation of how these two are connected to the outside world? And it's important to do that by grounding it in what it is that we do as humans. What is it that we do as humans? How does that result in a drop in resource in our health? Well, this is a map of how we live from Bureau of Labor Statistics, where we spend our time doing: working, sleeping, leisure, caring for others, being in a household, eating. That's what we spend our time doing. It is our underinvestment in those forces that shape our life in those times, where we live, where we work, and where we play, that results in the link between resources and health. It is our underinvestment in resources, like our education, our nutrition, our opportunities for recreation, our income and poverty, in our housing, in people being isolated and being at risk for poor mental health, in the environment. It is our underinvestment in those forces that explain where we live. It is that resource inequities and an underinvestment in these forces that result in these health gaps, health shortcomings. And just to be concrete about it, to use one example, and to focus, for example, on the black-white difference, because I've talked about that a bit. These are 6 graphs that really represent how black-white inequity and the fewer resources available to Black Americans result in worse health for Black Americans. So starting on the left, top left, you have unemployment rate over time. All these are over time. The black is purple, white is blue. Black unemployment consistently higher than white unemployment. Second graph, more white Americans than Black Americans completing college. Next graph, higher income among white Americans than Black Americans. Next graph, more home ownership among white Americans than Black Americans. Next graph, more incarceration among Black Americans than white Americans. Next graph, higher life expectancy for white Americans than Black Americans. And when you see something like this, you realize you simply cannot have the conversation about health inequity without also thinking about the resource inequity and thinking about understanding what those resources are. And of course, a lot of those resources, we often use the social determinants of health to talk about them. And in some respects, social determinants of health is a bit of a clinical term. And I hope that by explaining them and going through them, I've been able to illuminate what they are. But here it is by way of schematic. This is from our 3D commission that I mentioned earlier. And what you're dealing with is all forces, from commercial to politics to governance to influencing our neighborhood to influencing our income, our education, our occupation, all of which intersects with our genes. And this shows it happening over time. And what we also talk about is things like emotions and values and luck and historical legacies all contribute to shaping health. So now, having made that case, having made the case for the inextricability of resources and health and the inequity in distribution of resources, which is linked to the inequity in distribution of health, let's talk about data. Let's talk about how we can use data to inform our measurement of these multiple determinants of health to the end of making better decisions. This is the report I talked about earlier, which informs all this thinking, and this is available online at 3dcommission.health. And what we talk about in the report is how we need to think about integrating the full range of data available to us from everywhere, from mobile phones, remote sensing, combining it with sensors, etc., to create a data environment, all of which actually informs us and all of which can help us measure to the end of measuring the multiple determinants of health, moving beyond this notion that health is simply measured at the level of disease measurement through medical records or EPIC systems or even through surveillance systems, but to think about ultimately understanding the full net of determinants that generate health. This is another schematic that talks about how we get there and talks about ultimately the social determinants of health, which are the blue squares, have historically competed with competing priorities, which are the hatches, and the data sources sort of all competing to get to decision-making for health. But what we really want to do is create a matrix where we are constantly in a world of data that measures the determinants and the resources available to us that shape health, and that measuring health is inextricable from measuring those resources. For anybody interested in a deeper dive, and we're going to spend much time on it here, the Commission articulates principles that we think are important to that kind of data thinking, which says that evidence-informed decision-making is needed, and decisions about investments should always happen with health in mind. They need to always have health equity at its center, and we need to think about a full range of data resources that are transparent and accountable to the populations. That's broadly what the principles talk about. And then we have a set of recommendations that are really about creating systems to collect the range of full determinants of health transparently, monitored with accountability, and engaging communities in the collection of the data so that we can measure well the determinants of health to the end of creating an environment where we invest in resources to make everybody as healthy as possible. So let me now talk a little bit about how one can take this lens and apply it to advancing health equity in the global context, and then I'll start to wind down because I want to make sure we have time for questions. So fundamentally, to advance this vision of health equity that is well centered in data and the data resources available, one needs to have trust in data. It's certainly an issue of high salience these days, as we all have seen in the context of vaccines and the lack of trust in populations. But we need to make sure we have the technical capacity to have data measurement of the multiple determinants of health, the political will to do this, and the engagement of communities. And we have seen how a failure of any of these dimensions, the technical capacity, political will, community engagement, can become very real failures. For example, in the context of COVID and COVID vaccines. Now, we've had reasonable success with vaccines in 65 and up, with 95% of people who are vaccinated, at least one dose over 65. But when you look at who has gotten vaccinated in this country, you see the top row, each of these bubbles is a county. The top row are the most vulnerable counties in the country. The bottom row are the least vulnerable. And what you see is that the average of where most vaccine has been delivered is more in the least vulnerable counties rather than the most vulnerable counties. And if that is not a failure of trust, of technical capacity, of political will, of community engagement, I don't know what is. Because this, of course, speaks to the inverse care law, which was, by the way, articulated 50 years ago, 1971. The availability of medical care tends to vary inversely with the need for it in the population served, which means we give more medical care to populations who don't need it. That was 50 years ago, and we're not much better than that today. And I think fundamentally, fundamentally that reflects a failure of trust, of technical capacity, of political will, and of community engagement. And we, all of us in public health, have a responsibility to push against that. There are things that we know can be done. There are efforts that we know can be done. This is actually, I'm going to show some data. This is actually all in the High Five initiative, all on the CDC websites, showing, for example, that investing in public transit results in improving health of residents of cities. That when we provide financial support for habitable housing, we double mental health of residents who live there. When that early childhood education has a 5-to-1 benefits cost ratio because of its reduction of crime rate, child maltreatment, teen pregnancy, academic achievement. That expanding things like the earned income tax credit increases, every time you increase it by 10%, we drop infant mortality by 23 per 100,000. And we have papers that like this one that look at modeling, for example, and show that if we invest in over time in not just in better healthcare, but also in global payment systems so that physicians are incentivized to generate health, but also with healthy behaviors plus socioeconomic opportunities, that's when we improve health the most. That's when we reduce things like chronic illness the most. So we know this. And this is to talk a little bit about the inverse care law. Take it for a second. The inverse care law operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. Of course, we are in a country where medical care is dramatically exposed to market forces because of how we approach our medical care in this country. And this looks at the role of private and public wealth in rich countries, in which these private wealth has increased dramatically in all rich countries, particularly in the United States. And we, as a country in particular, in terms of public, are vastly over-invest in health care, which is what you see down here, much more than the average other countries. And we do that and we leave that up to private wealth, which is then where our health suffers and where we really come into this inverse care law, where we're helping people who really don't need to be helped and not helping people who do need to be helped. So let me start wrapping up. I'm going to conclude in the next couple of minutes. And I want to conclude by talking about the story of health and say, well, there's one of the points I get when I do a talk like this is, well, what should we do about this? What does it take? And in part, I think what it takes is telling the story of health and telling the story of health better. And we are not very good at telling the story of health in this country. When you look at the survey that our group did, there have been others like it, where we ask people what primarily causes your health. You see the answer that's mentioned most is healthcare, medicine, and doctors. Politics is mentioned by only 3% of people. I would probably invert this. If you ask me what primarily causes my health, I think primarily it's politics. I mean, if we ever needed a stark, horrible reminder of it, you can look at the war in Ukraine right now to see how political imperatives in Russia result in an invasion of Ukraine, resulting in terrible devastation to the health of populations. Politics is what really shapes our health. But we don't understand that. Now, why is it? Well, we have actually shifted away from narratives that explain this. This is from a Surgeon General's report released in 2021, looking at health and economics. And the way to read this is if you look at the bottom bar, this brownish areas are achievements in public health, things that we would all recognize: sanitation, safety, abolition of slavery, non-discrimination, voting rights, K-12 education, safe transit, conservation of parks. The purple, which is beneath that, is advances in medicine, things like biomedical training and funding, health insurance, transplants, drugs, devices. Now, if you look at the top, you see the mentions of these in our public conversation. The brown line is the mention of public health, and you see it really has been flat for really the past 80 years. But look at the purple dot, that's the mention of medicine, and see how it's skyrocketed since 1960. So in the past 40, 50 years, we have shifted our conversation where we talk much more about technological innovations and not about the multiple determinants of health. And our data thinking has focused on medicine rather than about the multiple determinants of health. And that has been to our detriment because we have not had this conversation. And when we write about health, if you do a search, a Google search on health, you find a lot of great books on health, and they're almost all about a medical individualized approach to health rather than telling the story that I'm telling you here. And in fact, when you look at the literature, forget about the public media, this is actually literature on global health. And you see, what is global health literature about? Well, It's actually about outcomes, about maternal child health, about infectious diseases, about surveillance, about research methodology, about sexual reproductive health, with very little about the broader rubric of social and multiple determinants of health. I want to conclude with COVID, because we've been living through COVID, and it's really hard to think about public health without thinking about the lens of COVID, given how all-encompassing it had been, given the tragedy of COVID as we approach 1 million lives. COVID has affected us in so many ways, and it affected us tremendously unequally, as everybody here knows. That when you look at death, for example, just focus on death, which is the bottom row, you have Black Americans or Latino Americans or American Indian American, Alaska Native Americans, twice the death rate compared to white Americans. And we all know that. But what we often forget is why that is. Well, the reason why that is because of everything I've talked about here. It is because of inequality and inequity of economic opportunity, for example. So if you look at, if you look at your ability to work remotely, it was entirely patterned by income. You see, these are income quartiles. If you go from left to right, you have more income quartile, more ability to work remotely. More income, more ability to work remotely, more able you were to protect yourself from a novel risk. And of course, our income is inextricably linked to race. And what you see is Black Americans are more likely to be in frontline jobs, to be frontline workers, to be grocery convenience store workers, public transit workers, trucking workers, building cleaning services. And these are the positions that expose people to this novel risk of COVID-19. So number one, there was a greater risk of exposure to COVID-19 because of underlying economic opportunity, which is what I've talked about right from the beginning of this talk as being foundational to thinking about resource inequity. And then secondly, because of underlying health inequity that pre-existed before COVID. We've known right from the beginning of COVID, this is from China CDC in February of 2020, showing that underlying death rate is higher if you have cardiovascular disease, diabetes, chronic respiratory disease. These are all these percentages. And of course, it was those underlying diseases were not evenly distributed, because this looks at Black Americans, white Americans, Black is blue, white is red. Black Americans, higher high blood pressure, higher diabetes, young ages, middle ages, older ages, all of which is due to this long-standing decades and centuries of inequities, resource inequities that were underlying health inequities that in the time of COVID became tremendous risk for disease. And I think we shouldn't forget in the time of COVID that it's not just about COVID. There has been a growth in other health conditions that are creating more health inequities as we speak. It's heartbreaking. For example, think about the rise in overdose. Overdose death rate rose about 30% in the time of COVID, and contrary to public perception, the rise in COVID in overdose is principally being driven by Hispanic and Black populations. This looks at fatal and no-fatal overdoses. The brown line is among Black Americans, and what you see is Black Americans have overtaken mortality than white Americans in the context of fatal drug overdose, really changing the narrative on drug overdose, reflecting once again how the underlying resource inequities become health inequities. I will stop there. I'll make a reference to, this is my latest book called Contagion Next Time, which came out in November, for anybody who's interested in thinking through the COVID pandemic in particular, through the lens of understanding how the underlying social determinants are what really shape the consequence of the pandemic, and hopefully thinking through how this can become a rallying cry for us to focus attention on these multiple social determinants of health, measuring them carefully and making sure that they become a foundation for all our decision-making. Absent that, we'll do just as poorly with the next pandemic, and our health will continue getting worse. I will stop there. It's really a privilege to be with you. I look forward to any and all questions.
Thank you so much, Dean Galea. This has been a really inspiring talk, and I'm kind of stupefied by the amount of data you have managed to present so cogently. I'll start with a question since there's nothing in the chat. So I was trained as a public health gerontologist, and one of the theories that has really driven my work is the theory of cumulative disadvantage, where we discuss how inequities at birth in health or in resources accumulate and are perpetuated by our systems and institutions And in the end, keeping these gaps the same or in fact widening them. And it is difficult to know exactly, I guess, where would we start to sort of break that cycle. I was wondering if you had any thoughts about that.
Yeah, thank you. I think a lot about this question, how does one start and how does one break the cycle? And I come down to almost always on this notion that we need to talk about it to break the cycle. We need to talk about it, and we need to talk about how harmful the cycle is for us. And I think the one communication mistake that we make, and by we, I mean those of us in this room, those of us in the room of public health, is that we allow the conversation to treat these forces as discretionary, to think it's a nice to have to deal with housing. That, well, as long as you have your medicines, then if we can get to housing, that's nice, but if you don't get to housing, as long as you have your medicines, it's okay. As long as you have your medicines, don't worry about structural racism. I mean, it'll be nice if we get to it, but that's okay. As long as we have your medicines, don't worry about having a livable wage. That's an extra. And the argument is actually having adequate housing, having a livable wage, not having systemic racism that results in holding particular groups back are inextricable from health achievement. Like, unless we deal with those, it doesn't matter how good our medicines are. And the example, the perfect example of that is COVID. Like, COVID was a triumph of medicine, right? We got to vaccines in 8 months, record time. We had not one, but two vaccines were 90% efficacious, and COVID still resulted in 1 million American deaths. We still had worse deaths than any other country per capita than any other high-income country. And why is that? It wasn't because we actually weren't fast on the vaccines. It wasn't because our hospitals were bad, right? Like, we actually, when you look at data within hospital data, once you got to hospital with COVID, like, people did as well as possible anywhere in the world. The issue was the underlying conditions that predisposed us to being so sick. It was, we're sitting ducks to these consequences of COVID because we had underinvested in the air, the water, the food, the housing, the education, the transportation, and all of that, which ultimately contributes to health. And I think we need to get better at making the case that that is not a nice to have, it is a must have in the context of creating better.
Mm-hmm. Yeah, thank you. There's a question in the chat about, you made a great point about how poorly we tell the story of health, and how can we help our students improve their storytelling skills? So what is it that we should be adding to their training?
Yeah, it's an excellent question. I think we collectively need to be making sure that we teach our students writing and communication, and encouraging our students to think creatively about how we communicate these stories. And I'll put on, ask Meredith from our team who's on this call to put in the chat. We're doing actually a Zoom symposium on, which we do every year. We do a Zoom symposium on teaching public health. And we're doing this one on writing and sort of best practices on writing teaching to our students, where we have a number of experts who are from all over the world who are coming to speak about it. But also I think that there is a generational shift coming, and I'm not pessimistic about it. I think the next generation coming in public health, they're great, and I think they're going to be better than we are, if I may, at telling the story of public health. So I suppose I see part of our job is to keep encouraging them, and they're going to think of better ways to do it. Mm-hmm.
I agree, and I think they're much more in tune with some alternate ways of disseminating health information that everyone can hear. There's another question in the chat about how can we shift the U.S. healthcare system away from market forces such as fee-for-service model that drive inequities in care delivery, and will technology such as virtual care delivery assist in disrupting the current model?
Yeah, it's there are two separate questions. Let me take them sort of bit by bit. I think the answer to the first question is we need to be clear that health is not healthcare, and that healthcare is essential. And this is not an anti-healthcare argument. Anybody who's read anything I've written knows I'm trying to be very careful about this. Like I'm a doctor. I want good healthcare. I want you to have good healthcare. When we need it, we want to have good healthcare. But by itself, it's not enough. And once you realize that we need to generate a conversation that says we need to invest in the other things, and those require thinking of health as a public good. And those might require creative approaches, things like different methods of payment of physicians. And those will emerge from this understanding. And, we are seeing that needle shift. Like you see CMS, Center for Medicaid and Medicare Services, for example, that has created a whole range of programs with incentives for health systems to engage in that. And I think that is a good thing for the world. The question is about technology will assist in disrupting the current model. I think so. I think there's a lot of things that are disrupting the current model. I think we also have to be careful about technology disrupting models, because I think, we get enthusiastic about pinning all our hopes on technology. And I think technology is a tool, but in no way is it a solution. But I do think that, for example, virtual care delivery to deliver services for people who normally don't get them, it can be a help. Again, we have to be careful to make sure that people who are getting virtual service are not getting second-class services compared to people who are not getting services. So I do think it's we have to make sure that technology is an adjunct to the broader principle that making sure people get as much good care as they can, but also aligning healthcare to align with the notion of generating health, not simply curing disease.
Agreed. Medical care not always equal healthcare.
Yeah, correct. Not medical care not always equal health.
Yeah, that too. So there's another question about, would you say intentional, effective, government-controlled, prioritized healthcare would make a difference? There's a lot to unpack in that sentence, as in some other countries where there is more equal care available. So that was.
Yeah, I see it. Yeah, I see it now.
Okay.
It just jumped on my screen as I was reading it.
Yeah.
I think we have to be careful that medical care or healthcare can only do so much. It doesn't matter how good it is. It can only do so much. It is not what causes the majority of health. That does not mean we don't want medical care. It doesn't mean that we should not have universal access to good quality medical care. It doesn't mean that at all. I mean, yes, we want all of that. We want universal access to good quality medical care, but we cannot expect it to do more than it does. What it does is it restores us to health once we're sick. Obamacare with the introduction resulted in a tremendous drop in the number of people who are uninsured, which is great. It did very little to our overall health. It did very little for overall health and life expectancy. And that's not a criticism of the ACA. It's simply what one would have expected it to do. So the argument that we should have universal access to quality medical care is a robust argument for moral and practical reasons, but it's a separate argument from the argument for creating health overall.
Yeah. So the next question is about tackling inequality of opportunity and its relationship with health. Should we focus on achievable interventions, such as increasing high school graduation rates at community levels, or continue pushing policymakers at the federal level for wholesale reform on taxation, as an example?
Mm-hmm. Yeah, I think I think my answer is yes. I understand that you're asking A or B, but the reason I think my answer is yes is because I think the answer is both. I've struggled with this throughout my career, like the idea of, do you work on what's achievable here, or do you keep work? You devote all your energy to the aspirational that will change things here. And I will be candid to say I struggle with that. And I think at this stage in my own personal journey, I come to that the answer is both. The answer is a bit of both. And I think I would encourage everybody in the audience to think about your sphere of influence. And if you disagree with me, then we can have a conversation. But if you agree with what I'm saying, then I think within your sphere of influence, figure out where you can have most impact, and whether that's at the level of policy making or whether it's at the level of achievable, what Anne calls achievable intervention in a particular context, and work on that. And I think it's all important. And the world lurches forward in sort of unpredictable, nonlinear ways. And if I had a magic wand, what would I do? Well, fine, I can say that, but it's not very useful, right? What is more useful is saying what can be achieved. And I think what each of us can achieve is different in all of our spaces. And I think we should focus on what we can achieve. And I think it all matters.
Yeah, thank you. So one comment in here is about whether we should reject the term social determinants in favor of social influencers, indicating that determinants might imply a predestined outcome, while influencer holds out hope that there is some agency to affect the outcome. So can you comment about the importance of sort of framing issues and choosing our words, and especially perhaps medicalizing different problems?
Yeah, I'll start with the second part of the question, which is on the importance of choosing words carefully. I think it's really important to choose our words carefully. I think it's really important to frame problems carefully. And I think we should think carefully about how we frame issues. Anybody who's interested in social determinants in particular, for example, groups like Robert Wood Johnson have issued primers about how best to talk about social determinants and how best to tell stories about social determinants. In the context of the social influence, I hadn't heard that, I must say, and I need to think about it. I think it's an interesting point. The different terms have been used, like social forces, social drivers. I'm actually more interested in dropping the word social. And the reason I'm interested in dropping the word social is because I think it's social suggests that there's other things that are not social, or in fact, I actually think that ultimately everything that's outside the skin is social. Anything below the skin is biologic. And there's a term which I've also seen used, which is multiple determinants, just talking about the multiple determinants of health, just saying there's a whole range of things that influence health. And if you saw my you were listening to what I was saying, I was using the term multiple determinants a number of times in my talk. So I don't know, Michael. I hadn't heard of this before, so I reserved the right to think about it a little bit. And but I also think that our understanding of language changes, and our understanding of what things mean changes and gets better. And I'm open to shifting my thinking and my understanding as it evolves collectively. I'm glad to read this. I hadn't heard about it, and I would encourage us all to think about these things and learn and get better in the terminology we use over time.
Yeah, thank you. Other questions from folks? So after all of your research, data compilation, dealing with the pandemic, where do you think public health should go from here, in your opinion?
Mm-hmm. Well, here's the controversial answer. I think we're in a good place. Now, I know it doesn't feel like it. We're all battered by the pandemic. It feels like, we've been sort of beaten up. I think public health broadly feels like it's been beaten up, but the world is aware of public health. The world's aware of what public health can do. I look at our students and they're outstanding. I think they're committed to public health. I think there's going to be jobs in them in public health. So I think those of us who've been in public health for a while have a real responsibility right now, both to tell the story right, to channel this energy into public health, but also to prepare the next generation. And so I think it's a good time to be in public health. And not just being a good time from a place of a satisfaction to be engaged in a really important mission-driven enterprise, which I think it is. But I think it's a good time practically in that the scope for our engagement has to grow. It only has to grow because the world ultimately is a rational place, I hope, and it will recognize that the importance of public health. So I think if there are any trainees, particularly in the audience, you've chosen well. This is a good field to be in.
Yeah, I agree. Other questions, folks? So I know this is from one of our MPH students. As the government structurally becomes less and less responsive to the basic needs of regular people, what strategies can we as public health professionals employ to help overcome the lack of political will to address these critical issues?
Yeah, I think we can be strategically engaged with government. Government is a very big word, and there are many levels of government. And it is for that reason that many of us have long been interested, for example, in cities, seeing cities as a place of potential innovation, a place of where there is much that can be done that sometimes gets caught in tremendous partisan gridlock at the national level. States have innovated on many things. So I would encourage us to work with levels of government that are where there is political will to innovate. I personally, I sort of like the idea of working with cities. I think many cities have shown themselves to be quite creative, and they're doing things. I mean, right now there are some really exciting projects around, for example, universal basic income, reparations for racism, and they're happening all at the city level. And these things are taken up eventually at the broader, higher government level. So I say, don't despair. I think engage with the levels of government that are responsive to as Ali puts it, to the basic needs of regular people. I think there are good people in government all over the place, and I think those of us in public health need to make sure that we find a partnership with those people.
I think it also highlights really the need to train students on advocacy and the skills that you need to be able to talk to legislators using all forms of data, both qualitative and quantitative, to really make your case. So, well, if there's no more questions for Dr. Galea, I am going to turn the session back over to Mike Doolin to close us out. Thank you so much, Dean Galea. Everybody, if we could have a show of hands for Dr. Galea's presentation, which is very thought-provoking.
Yes, I'll just echo my thanks. What an awesome presentation and great way to close. And I particularly like those ending comments about don't despair. It's a good time to enter public health. And there are a lot of good people in government that are doing amazing work, which is definitely resonates with me. So by closing, I just want to thank our speakers, Dr. Washington and Dr. Galea, who really inspired me to think more about public health, what it means locally, nationally, and globally. And Dr. Warren Finlow, our amazing moderator for both speakers this afternoon, as well as the facilitators and panelists for so generously giving their time to make the AAFE Nexus 2022, our sixth annual Nexus, a huge success. And I want to thank each of you for being part of Public Health Week and helping us to learn more and explore more around public health and what that means and what the opportunities are. I just wanted to remind everybody that there are going to be recordings of the sessions as well as slides available. They'll be on our website, which is AAFE Innovation. It's AAPHINNOVATION.org. You can find all the recordings there. Michael also mentioned that we're providing professional education credits for the presentation. So make sure that you also look online at our website for further information about getting those credits. And then finally, our survey you can see in the chat. Michael has, there's also the question about when we will be able to view the presentation. We'll try to get it up by next week. There's the registration forms and our evaluation form. This is extremely important to us. Every year we look really closely at the feedback that we get, and we try our best to address the issues that arise and shift the meeting structure to meet the needs of our participants. I also want to thank our AAFE core team. So Pat Robinson, Victoria Scott, Michael Thompson, Carrie Birch, Mike Kennedy. I was glad to see him still on here, even though he's temporarily left the core team. Michelle Issel and Maren Kaufman. I also want to throw in the chat, and I think you may have seen from the slides, but there's also a scholarship fund honoring Maren, and here's the slide as well. Thank you for putting that up. Maren was one of the founders of AAFE, and I know she was present earlier during the meeting, so please consider the annual giving campaign, and the directions are here if you would like to make a donation to the Maren Kaufman Scholarship Fund that will help support nursing education. I finally also want to thank Dr. Michael Thompson for all of his work to create the continuing education credits, and Julie Carroll, whose amazing support behind the scenes. This meeting would not be possible without her organizational superpower that could be seen in almost every component of this meeting. The ISLE group, which also did an amazing job behind the scenes supporting the work. A couple of reminders, the MedLink Forum is happening next week. We'll have some of the same speakers. Dr. Washington and Trinavia will be speaking at that. And then our Department of Public Health Sciences is also sponsoring the NC Breathe conference as part of Public Health Week, which I believe will happen in just a couple of days. So thanks again. We really appreciate your attendance and your support of AFI, and look forward to hopefully next year seeing everybody in person. So thank you again. Hope you have a great afternoon and enjoy Public Health Week.